Another big strategic document has dropped from the Department of Health. This time it's entitled Joined Up Care for People, Places and Populations. What is this going to mean for general practice as we move forward to 2022 and beyond? Well, let's find out with EGP Learning. Hi, Gandhi. So we've got another big strategic document that's dropped from the Department of Health, it's really difficult, isn't it, for people to keep their eye on these new strategic documents and understand the contents when there's so much happening day to day. So I'm looking forward to us having a look through, introducing people to the document, hopefully reducing that barrier of entry for people to pick it up and start to dive in and help them understand what's going on, really. But how are you doing?
Doing quite well. And you're right, it's a bit of an interesting document because it's a little bit different to the ones we typically do. We tend to dissect all the documents from NHS England in terms of contractual stuff and other changes that happen for general practice. This one has a completely different connotation, doesn't it, Andy? In the fact that this is talking about integration of health and social care, possibly the two biggest things that could happen in the journey of a person's life in terms of the services that deliver for them. What do you think?
Yeah, it's interesting. It is a different sort of document. This feels like more of a blue sky, earlier in the development of a concept type of document than we normally get, because we're normally picking up those documents that come out as they're being implemented
Hmm.
in primary care and in the NHS. So this is going to be a slightly different experience. But as ever, what we're trying to do here, I think, is just reduce that barrier of entry to people, let them know what's in the document.
Hmm.
We probably won't have time to go through the whole document, and I think it's probably sensible to focus on the executive summary, which does summarize the general contents and general thrust of the document, and people can dive into any piece of the document that they find particularly
Hmm.
interesting for the detail. I know we might be diving into the digital component in a future episode as well. Is that right, Gandhi?
Yeah, that's the plan. So we're going to go through the digital part in a separate episode. So definitely check out, and the links that will come at the end of this one. So if you want to follow through when we publish that. But as you said, let's go through the executive summary. And main reason for that being this document is massive. It is huge in content. So that's why we're focusing on the summary itself. And that should give you a flavor of what you need to be aware of in terms of this whole plan to join up care for people, places, and populations, as the document is called. Take us through it,
Yeah,
Andy.
yeah, I think it is quite an interesting document. So, um, as ever, always worth spending a little bit of time on the contents page, because that does give you an overview of what's in the document,
Hmm.
and it's a great way to start to understand them, even if you're not going to look at the whole document. But I think we'll move through that. We'll just have a few words just on the forward here. So it's by Sajid Javid and Michael Gove, and really what they're doing in this forward is acknowledging the pandemic that has happened and the good work that has happened within the health and social systems, and particularly around the vaccination program. They are reflecting on some of the unequal effects that COVID has had on the populations of the country. So
Hmm.
we know that certain populations, due to their demographics based on race or poverty or obesity and other factors, has been unequal. So they reflect on that and say that it highlights disparities that were there in society before. There's a link in with the Levelling Up agenda. We can see Michael Gove's face there, Minister for Levelling Up. So they're linking in the whole kind of leveling up sort of political concept in with this document as well. And they're saying they're going to take a patient focused approach, which is always really, really good. They mention this concept of single accountable person
Hmm.
for providing and linking up things, which is a theme that runs through the document, and we'll come to that later. They talk very much about the need to join up social and health care to work together on this leveling up agenda. There's a particular mention for sharing data, and they particularly mention a focus on healthy life expectancy and access to quality care. So all the sorts of things, I guess, that you might anticipate would be in there. Any
Hmm.
reflections on the forward or the contents, Gandhi?
No, like I say, it's a nice summary of stuff, and it's got some pretty pictures of people that are telling us what we're going to be doing and stuff. So, hey, not bad.
That's cool. So let's come to the executive summary, which is the meat and potatoes of what we're talking about today. So the start of the executive summary really starts to set the scene and gives the context in which we are delivering this document. So it talks about learning the lessons from the pandemic and then carrying them forwards into the future. Again, it's talking about a lot of the good work in a little bit more detail around good practices of local working at community and place level, good work by neighbourhood teams, all working together to provide various support for COVID. Talks about the need for a commitment to go beyond traditional organizational boundaries going forward. So they're sort of saying, actually, we broke down some of those boundaries during the COVID response between different parts of the NHS and between the NHS and social care, and that's good
Mhm.
practice, and that could probably be a lesson learned and go forwards to. And they actually talk about bringing together resources from the NHS and local government in a more real way, and that's something that's been talked about for a long time. So that's really setting the scene. So yeah, progress made, but problems remain. And they're really talking about identifying a few problems here. So they're reflecting that actually often the goals and priorities are not often aligned across different organizations in the NHS in a way that allows prevention to be prioritized. So
Mhm.
we've talked about these sorts of things before, but the hospital trust might be paid and incentivized in a certain way that ensures a focus on certain activities or delivery of operations and so forth, and doesn't necessarily focus that organization so much on the preventative measures that might reduce the overall disease burden to society and the overall cost of delivering the health interventions in entirety, if more resources were focused on prevention, in a place that wasn't the hospital, but out in the community.
Mhm.
So it talks about aligning those priorities better. Um, it really talks about tackling unjustifiable disparities in outcomes. And I really highlighted the word here, outcomes. And I hope that this is deliberate because it's not talking about disparities or inequality in access or achieving equality of access. It's talking about outcomes. And those things are really, really different. And we both work in very deprived areas.
Mhm.
And I'm often frustrated that a lot of interventions coming from government focus on universally increasing access, and that doesn't universally increase outcomes. Some people already
Yeah.
have quite good access and already have quite good outcomes, and actually maybe the focus needs to be more on getting everybody to the same or similar outcomes rather than access. So I actually thought that was significant for me. What do you
Mm.
think about that, Gandhi?
I agree, and we talked about some previous streams that things need to be locally derived and stuff in order to meet the needs of the population better, rather than the blanket all approach and stuff. And that also applies to outcomes rather than access, because we know that access doesn't necessarily lead to good access doesn't always equal good outcomes. I think that's a misnomer, and that's one of the policies I think a lot of people have held for a long time. And actually, we've realised that that's not the case.
Yeah. So I'd really like to hold them to that. And I hope they're serious about
Mhm.
universally improving outcomes. So they also talk about supporting services to work together better rather than against each other. And gosh, that I just think back to my medical career, and that is so true. I remember being, receiving uh, referrals in, say, from general practice or other organizations when I was on call as a junior doctor at the hospital. And, you've got a finite resource there. And often the objective is to try and limit or reduce the amount of referrals in that you accept. I know that may
Mhm.
not be completely right. And there was always an emphasis on, making sure that the patients got what they need. But there was always that
Mhm.
tension between the different organizations. So that's just a real example of that. And they're talking about trying to break down those frictions, which I think is a good aim. I think it's going to be difficult,
Mhm.
but I think it's a positive aim. And then they talk about, okay, the specific aims of this paper, which they break out into bullet points. And they're talking about, right, we want to deliver person-centered care. Not the first time we've heard this, but I think it
Yeah.
is a very positive aspiration to deliver. So things wrapped around the person and the person's specific needs. Um, they talk about place an awful lot in the executive summary and the rest of the document. And for me, place generally means that level of NHS organizational structures, which is the ICP. So given the context that they're using the word place, I think that is what they are referring to, or perhaps smaller ICSs. But they say that will be the engine of delivery. So I think we're going to hear a lot about place.
Mhm.
They talk about having a single person accountable at the place level. They talk a lot about this single accountable person. It sounds like it will be a big and important job. And it'll be
Mhm.
interesting to see whether they use a role within the existing structures or whether they create a new role for that. I'm imagining there's responsibilities for health and social care. So it'll be interesting to see how that works. But that's a big part of this document as well, shifting some of that accountability and responsibility locally. And then they also talk about integration. So that's another big theme here, and integration in some areas of workforce, integrating digital data usage. They talk a lot about pooling of finances, and this is something which was coming with
Hmm.
ICSs anyway. But they talk about pooling of finances across NHS organisations and potentially across social care organisations as well, and also the alignment of objectives along with aligning those financing models across organisations. And they talk about doing this within place. That word again, place.
Hmm.
So yeah, what do you think feel about those overall objectives, Candy?
I think they sound relatively okay. It's going to be obviously the key point comes into the implementation and what the outcomes of this looks like. I think that emphasis on places, I think the key part that you're talking about is going to be really difficult, I think, for some people to envisage and interesting for others to action. Important to remember that when we're talking about place, so we've done that episode earlier that kind of explains the structure of the healthcare system. So at the bottom, you've kind of got your GP practice, which is your tiny little Lego block. You've got your PCNs, which is what me and you are involved in terms of being the slightly larger Lego block, and then you've got your place, which is your your ICPs effectively, which is a combination of networks that form that kind of wall for your area. And the ICS is the whole building kind of thing, all the walls put together. And then the roof is kind of the NHS England, Department of Health on top of all of that. And that's your healthcare system. This is bringing in people from outside to form those walls as well in terms of social care and building up the whole contents of the whole house in terms of what forms then healthcare delivery as well as the social delivery to a person's health and well-being. That's my understanding of what this is trying to do. Does that sound okay?
Yeah, that sounds good. Yeah, and the key thing here for me, I think, is an emphasis on um, pooling finances and objectives,
Mhm.
which I think is really, really, really tricky to achieve
Yeah.
because the different organisations have their own, their own budgets and objectives and their own
Mhm.
needs in terms of their own survival. So it's a really tough job to try and align all of those things. But it's
Mhm.
something that we've talked about before. People have been talking about for a long time, and their objective is to try and enable the shifting of resources towards prevention rather than uh, treatment. At the end, once your
Mhm.
adverse event has happened, once the person has got diabetes and they need an amputation, rather than focusing resources there, trying to stop people getting to that stage by focusing on prevention. So they're talking about
Mhm.
setting up the mechanisms to enable that to really happen this time. Hopefully, that's the
So
objective.
how are they gonna do that then, Andy? Let's talk about the rest of the summary.
Yeah. Um, So they're focusing on the individual areas there that form the key themes really. So the first of those is joined up care. So some keywords here in the joined up care section are joined up, obviously. So they're talking about
Mhm.
getting different organisations to talk to each other more and share data and resources, as has been the implication of some of the things we've said earlier. And the other keyword they use a lot of is closer as well. So they're talking about closer working between organisations, primary and secondary care, between physical and mental health organizations, and it's about closer to home as well, which I think is again something that we've heard about a lot, but moving services closer to the patients and not necessarily moving patients closer to the services. And they also talk about the use of data, and that's another separate theme in and of itself. But the unlocking of the power of data and digital to enable some of these changes. So that's
Mhm.
positive. So yeah, I mean, joined up. Any reaction there?
I think it'll be interesting to see how this looks, as we talked about earlier. I think joining up staff and working them close together is nice in principle. I think there's a lot of culture change that needs to possibly happen to make that functional, and that'll be the interesting part, how much they develop and deliver in terms of that culture change that needs to happen to make that more effective and stuff.
Mm. Yeah, in some ways, a lot of this is pretty obvious stuff, isn't it?
Yep.
Really, it's obvious that these things would be helpful, and it's not things that we're hearing about for the first time. But I guess they're pulling it together in another place to have another push at it. And it
Mhm.
just feel like we're getting closer to these objectives, actually, slowly over time. I think. So
Mhm.
it's about shared outcomes which prioritize people and populations. Um, so uh, they're talking about, again, this is about aligning the outcomes across different organizations. And there is talk of enabling some, it's unclear how much, of these priorities to be set locally. And they talk about, again, place comes through a lot. And they talk about setting up local objectives and aims at the place level. Which I think is really sensible. And we've often talked before about how um, problematic it sometimes is to take something which is good practice in one place and has a big impact on populations in one place, and then just assume that that's going to work everywhere in the country, whether that's
Mhm.
an urban or rural setting, a deprived or affluent setting. That can be a really problematic way of rolling out interventions. So I'd welcome this increased emphasis on place and local devolved decision making, which I think is
Mhm.
really
Agreed.
sensible. Just highlight on that. I did a control F find because I thought, how many times are they going to talk about primary care networks in this document?
Mhm.
Because often in these documents they're named a lot, but there's actually only two references to primary care networks
Mhm.
in the whole document, and both of them are sort of talking about existing practices that happen within primary care networks, which I thought was interesting. They talk a lot
Mhm.
about neighbourhood and about the layer below place, but less specific talk of primary care networks, which is a surprise because they're normally very, very heavily
Mhm.
emphasized. And uh, I'm sure activity will be taking place at the neighborhood level. And it'll probably be under primary care networks, but I just found that that was interesting. And the emphasis really is place and ICP level. They talk about strong leadership and accountability. So this section really talks about the pooling of the resources, the creation of locally shared plans across those organizations, and then the tracking of the delivery of those outcomes um, in a very real way, so that people can see that they have been delivered. So that process will be really, really interesting. Um, and then they talk again about this single accountable person, which it's just really interesting that keeps cropping up as a theme. Um, and they talk about the integrated care board, which I don't think is a new thing. I think it's something that sits alongside the ICS at that level.
I think it's the people that's gonna be running the ICS, actually. So ICS is the geographical area, and the ICB are the people that run it.
Yeah. They're saying that this proposal will not change the current local democratic formal accountability officer duties within local authorities or those of the ICB. So I'm wondering if this is a new role
Okay.
that they're bringing in, but it's very
Mhm.
difficult. I think it's very early days to understand what that role will be.
Mhm.
Sounds like a big role with lots of responsibilities. I'm not
Yep.
sure it's a role I would relish, to be honest.
So,
Um,
are you gonna be that person of authority then, Andy, for the Nottinghamshire area? Would you be interested?
I'm going to definitively take my hat out of the ring for that one.
Fair enough.
Um, I'm sure. How about you, Gandhi?
Nope. Have no intention of going for this. This sounds like an interesting opportunity, but also a ridiculously challenging one.
It does, but probably an opportunity to do a lot of good, in terms of
Mhm.
bringing those organizations together and, setting the plan, working with your organization that will sit beneath you and support you, one
Mhm.
imagines, to set the plan and the KPIs and the objectives for the area. So really big role. It's probably looking at a big beast, isn't it? Someone with lots of
Mhm.
experience and skill. And then, so they talk about, financial integration is one of the other mechanisms of achieving these goals, which they talk about. So they're talking about and emphasizing this alignment and pooling of budgets across NHS and social organizations with local flexibility to
Mhm.
determine what that means and how that works. Um, what are your general thoughts about integration of NHS and social care? When we first started talking about this as a concept, my
Mhm.
initial reaction was, okay, the NHS is underfunded, but it's funded a lot better than social care, which
Yep.
is really, really underfunded.
Underfunded.
And
Yep.
my immediate concern, which probably signifies some of this kind of siloed kind of attitude, was, gosh, they're going to take money from NHS services to plug a gap in social care that perhaps more appropriately should be plugged with general funding from government or council taxation or some other route. And it kind of worried me. But what were your feelings, Gandhi, on this as a
I
principle?
personally, the cynic in me is coming through in this, and I think it's very much the reason they're doing this is just then they can underfund both of them even more because then they can share the funding as they keep mentioning multiple times, and therefore actually it's a way of putting less in because by theory of this, have economies of scale that mean that you can save money in different ways, and that's what they're hoping will come from this, and therefore reduce the overall budgets to both elements of it, with a view to having to pay less.
Oh my goodness, you are cynical, Gandhi.
I am
But
cynical today, aren't I? I wonder why.
well, but yeah, no, we'll see, and then they can blame the accountable officer, can't they, when it all goes wrong?
Exactly. Yeah.
But
Hence, very clearly, why I don't think you or I are ever thinking of taking on this role, to be honest.
yeah, on the other hand, we have seen more funding come to the NHS, through
Mhm.
through COVID. Um, you know, actually, if these sorts of measures are funded sufficiently, this could be really, really
Mhm.
powerful. And the shifting of an emphasis from treatment to prevention could be really powerful and cost effective as well, and reduce suffering of people.
Mhm.
And the breaking down of the barriers between organisations, getting workforce talking better to one another, actually could release cost savings as well as making the experience of receiving care and the outcome from that care much better for patients. So
Mhm.
I, I'm
Interesting.
not. I don't want to be too dismissive of the document, although I share your cynicism around
Mm.
funding. And then, so this section, so this is a bit more sort of our bread and butter, really, here, isn't
Yeah.
it? There is an individual section on using digital and data. So the emphasis, so some interesting things here was they are suggesting that they will have a single functional health and care. So I'm thinking social care record by 2024.
Mhm.
Is that achievable? Do you think, Andy? It would be
Well,
great, but
so that's 2 years away. That sounds like a long time, but when you're talking about integrating data or repositories, that's a really short time frame, because there's so much stuff that needs to happen in between there, and then, again, education and culture changes in terms of how you record and use that data and stuff. I mean, they've been trying to do this for years with healthcare. How are they gonna manage to do that with another complete separate organization? It does question the opportunity and the ability to make this happen. But hey, it's what they're saying they're gonna do. I mean, for us in primary care, does this mean social care is gonna be using System 1? Does that mean we're gonna be using a completely different healthcare system? Or is it what it should be? We just use systems which interoperable between each other, um, which is always the nirvana, as I've seen that recent term used in a discussion about interoperability. Will it happen finally?
it's going to be interesting. There's a few ways this can happen, I think. So it can't happen from scratch, and we're not starting from
Mm.
scratch anyway. There has been a lot of work done recently, I guess, on interoperability of records, and maybe they feel that those will come to fruition by 2024, or can be accelerated
Mhm.
to do so, which is one way we can get there. Also, there's a big emphasis on place and local, and I'm wondering, one way you could achieve this is for a place to just say, right, we're going in with EMIS, we're going in with Vision, we're going in with System 1 across
Mm.
everywhere, and make a procurement decision like that, and kind of just get everybody using the same system. Therefore, locally across at least that place, there'll be a single unified record. So there's a few ways to get there.
Mhm.
If it really is a priority and people really want to get there, then I think it perhaps is achievable. Although you're going to have to get there via kind of uh, you know standing on the shoulders of things that already exist, like
Yep.
the clinical record systems that we have, or the interoperability systems that are already getting towards maturity. But having data in one place, accessible across several organizations, would be absolutely amazing
It
um,
would.
for patient care. And we might be one of the only places in the world that does it effectively. That would be absolutely fantastic.
Yep.
A few other things which are quite interesting is they talk about data and digital training for staff.
Mhm.
If I was someone in the business of designing training modules and things like that, I think, okay, well, there's an opportunity here. There's a need. There's a need
Mhm.
here to really upskill NHS staff for digital. So people are going to have to meet that need. So I think that's interesting. And they talk about actually an emphasis on digital interventions for patients and enabling staff to be capable of supporting them with these. I think this is quite good actually, because digital interventions, new and emerging, although fairly, established way of treating all sorts of things. So it's good to see emphasis on that. And I like the emphasis actually on just getting the day-to-day staff of the NHS capable of supporting them using it, rather than having necessarily dedicated tech support teams or dedicated groups of people promoting adoption. Actually just get everybody doing it. Digital's part of our way of life after COVID, I think. So
Mhm.
I think that's quite good. Any reflections on that? I know we're probably doing an episode
No,
on
we're going to go
this
into that in
section.
more detail in a future episode. So yeah, no, happy to leave it there for now.
Watch this space. They talk about integration of the workforce, workforce and carers. Interesting. Carers,
Mm,
well, often carers are part time, aren't they? Unfunded and so forth. So, but it's just interesting that we're talking about, kind of bringing those in the same. Speaking of those in the same breath as workforce paid people, thought that was interesting.
mhm.
Uh, so they're talking about getting staff working together for the patient, regardless of who they work for. And again, it's a great aspiration. Really difficult in practice. Do
Devil
you
will be
think?
in the detail as ever. But I think that sounds a little bit optimistic to me. But
Yeah,
we shall see.
it does. It does. At least it's going hand in hand with an aspiration to do something about finance, because
Yeah.
often where this falls apart is, a patient is sat with one service and they need something which is a little bit different and delivered by another service.
Hmm.
But then in the eyes of that other service, they reassess and they don't think that they need that and what they need from another
Hmm.
service. And it creates gaps that people fall through. So an emphasis on, both of those organizations needing to work together where someone falls between a gap between their organizations, to actually find a solution would be really, really helpful. Because I know our experience as primary care is, well, they're falling between, say, let's say, a psychotherapy service
Hmm.
and a true, psychiatric intervention service. They fall between that gap. And what tends to happen is when they fall between that gap, they don't land on either of those services.
No.
Both of them often do not take full responsibility. They land with general practice again,
Yep.
who aren't equipped or funded or supported to actually deliver what the patient needs. So, an emphasis on closing the gaps with workforce actually
Mhm.
working together. That can only be positive, I think. And then this emphasis on place. So joint health and care workforce at place. And they talk about workforce planning here, which I think is interesting because that's about getting the right numbers of people in the right roles, in the right places, in the right organizations. And I think of some local problems that we sometimes have with disparities, say across Nottinghamshire, with the willingness and availability of general practice workforce to work in some areas compared to other areas. They're
Mhm.
often gravitating towards more affluent areas as opposed to
Mm.
private and challenging areas, and that there might be an emphasis on correcting that within these sorts of aspirations. Sounds positive, but we'll see.
Absolutely. I think that's something that many people will be encouraged by if that was to come out of the outcomes.
And then the last few paragraphs of the executive summary, I think, seek to pull together what we've already heard and learned and put it in the context of the people and the communities. So really it's saying that for people, what this should all mean is that there's more information available to them about their care and their choices, that the system will act with their wishes and well-being at heart, that they will be empowered with decision making, that there's an emphasis on removing barriers between organizations that often impede their care,
Mhm.
empowerment of place and being closer to them, and both in terms of the physical delivery, but also in the setting of the priorities and the goals of the health and care service, closer to them, emphasis on their place, that there will be transparent and accountable delivery of outcomes. So I think that speaks to some of the oversight that is talked about and the accountability delivered by this accountable person that is going to be put in place, and that they should expect financial frameworks to support all of the above with a bit more emphasis on prevention. So
Mhm.
that's that's really what we were taking from the executive summary, I think.
Mhm.
Um, so having gone through that in its entirety, any final reflections on this document?
I think it's got far-reaching implications in terms of the integration of health and social care. I think it's got a massive mountain to get over in terms of achieving that. So it'll be interesting to see what the final kind of papers look like in terms of, as you mentioned, Ali, this is more like this is what we're planning on doing. This is what we're thinking is how it's going to look like, but it's not the nuts and bolts. This is what you have to do document that hasn't come through yet. And that's what we're probably more keen to see because as ever, that'll have the practicalities and the detail as to what this actually looks like. But there are some serious challenges in this plan, which could, if done well, have really far-reaching implications for the benefit of the health and social care of our population, also some potential for it to go completely wrong.
Yeah,
What
it's
do you
good. I
think?
mean, yeah, I think it sounds like it's building on existing structures. So it
Mhm,
sounds like what currently exists isn't going in the waste bin, as sometimes happens when people come with a new strategy or an approach. So I think that's positive actually. So maybe we
yeah.
can build on what's there already rather than just disrupt it completely, as often happens when there's reform in the NHS. So I think that's a positive. I do like the focus on the words of outcomes rather than access,
Mhm,
because I think, and the linking with the leveling up agenda, because I think that perhaps suggests a genuine desire to do something about outcomes and to level up those people who are disadvantaged in terms of their access and their ability to engage with
mhm,
health. Not that the services aren't present for them, their ability to support with that, rather than just universally doing things about access. I really like that. And I like the emphasis on place and devolving the setting of kind of local um, outcome measures, objectives, and interventions to that kind of place-based level, rather than
mhm.
having us all do the same sorts of things nationally. So I think there are some positives, but the devil will be in the detail. And I often have a naturally cynical position, although I'm also, I like to think that it's important to give things a go, and you can't stand still. And
True.
the aspirations and aims are noble. So let's see what happens and see what's in the detail.
Absolutely. And if you want to see more of that detail, do check out our upcoming episode that talks about the digital aspects of this document in absolute more detail as we go through the various sections and parts of it. So that'll be really useful if you're interested in integrating detail. And if you want, that episode's probably coming up somewhere around about here. We'll get it pointing right in the right direction and stuff. And as always, EGP Learning is here to continue to help tech enhance your primary care and learning. We will catch you in the next episode. See you later.
Hello, this is Andy from EGP Learning here. I just wanted to pop up and let you know about an opportunity for existing or prospective primary care network clinical directors, network managers, and senior leaders to really hone their skills and learn how to navigate the challenging task of running a primary care network. Gandhi and myself from EGP Learning are working with Ben Gowland from the General Practice Podcast and Tara Humphreys from the Business of Healthcare Podcast, and we'll be taking a cohort of PCN leaders through a course later this year. There will be live webinars on topics from creating a vision for your primary care network, engaging practice members, PCN finances, managing the ARS workforce, network operations, and getting things actually done, working with partners outside the primary care network, and managing your own personal resilience and well-being to stay sane and healthy while you get all of this hard work done. We'd love for you to join us. So if you want to know more, please head over to www.thcprimarycare.co.uk/PCN plus to learn more. Now back to the podcast.